let me start with the first talk of this session. This is by Dr. Pcmanoria, a very renowned cardiologist all over the world. And he's giving a talk on running the race against heart failure, the progress made so far. Dr. Manoria.
Good morning, everybody. For the next 15 minutes, I will be talking on running the race against heart failure, the progress made so far. The last couple of years has witnessed a sea change in heart failure care, both in terms of enhanced understanding and in the availability of a panoply of newer therapeutic options. The 4 foundational drugs have kicked off a new era of drug revolution in HFrEf, and they are powered to improve outcome and increase survival. SGLT2 inhibitors have emerged as the first ever successful therapy for treatment of HFpEF after the Emperor-Preserved trial, and HFpEF no longer remains an orphan disease. SGLT2 inhibitors like AMPA can now be used across the spectrum of heart failure, irrespective of the ejection fraction, and we are keenly awaiting the results of the DELIVER trial. Very exciting data has emerged from the PROVE-HF trial. Sacubitril valsartan has transformed ICD-eligible patients with ejection fraction more than 35% to ICD-ineligible patients with ejection more than 35%, and this is indeed very exciting. Arni can now be utilized as a de novo strategy for treatment of HFrEf in patients who are naive to AC inhibitors in ARB, and switching over from AC inhibitor ARB to Arni is no longer mandatory. And another very strengthening development is drug revolution for HFrEf is poised to postpone device therapy like CRT, LVAD, and even cardiac transplantation. Heart failure, all of us know, once sets in, runs a malignant progression with a very high morbidity and mortality. Hello? The 5-year mortality is to the tune of 50%, a figure higher than most of the malignant lesions. Drug therapy, device therapy, only blunts this malignant progression and improves survival, but does not arrest. This is because the human myocyte is not endowed with an endogenous capacity for repair. Once dead, is dead forever. Cell therapy is therefore emerging as a very exciting option, but after several years of research, we still do not know whether it is the end of the beginning or beginning of the end. And surely we'd like to have comments of Dr. Narula on cell therapy. And therefore, prevention of heart failure has emerged as a very important agenda, and this is indeed possible. The treatment of heart failure basically revolves around drugs, devices, and transplant, and non-pharmacological modalities are used as an adjunct. Because there are separate sessions on devices and transplant, my talk is only focused on drug therapy for chronic heart failure. Now, this is the Esc Hf2021 Guidelines, and on the top you can see the must-do therapy, the 4 foundational drugs, and diuretics are utilized in the early phase of the disease. And we have several other drugs which I will be discussing. Now, in our ongoing war against heart failure, these are the old drugs, and we are very much familiar with it. And these are the new approved drugs: arni 1B, SGLT2 inhibitors, DAPA-AMPA 1A, Vericiguat 2BB, tafamidis 1B, and omecamtiv mecarbil is still under evaluation and not yet approved. Now, when we look at the treatment of heart failure prior to SGLT2 inhibitors, all drugs which improved outcome of HFrEf executed direction to neurohormonal modulation. We have 3 strong blockers for the maladaptive neurohormonal system, the beta blockers for the sympathetic system, The AC inhibitors, ARB for the renin-angiotensin, and the MRAs for aldosterone. And sacubitril valsartan increases the activity of the vasculoprotective neurohormonal natriuretic peptides. 2019 initiated dawn of a new era in heart failure when the DAPA-HF trial was presented, and DAPA-HF trial showed improved outcome of HFrEf, diabetic and non-diabetic, and DAPA-HF laid the first foundation milestone of SGLT2 inhibitors in the treatment of HFrEf, and it kicked off the era of SGLT2 inhibitors in heart failure. Besides, and then we had 2020, the EMPEROR trial, which showed similar results in terms of decreasing hospitalization for heart failure. And we have 2 other trials in the same year with sotagliflozin, which I'll be talking to you after a couple of minutes. Besides this, there are 2 other newer pathways for treatment of heart failure, particularly HFrEf. The soluble guanylate cyclase pathway, which is stimulated by verisugat and has shown improved results in the Victoria trial, and the myosin activation, which is executed by omecamtiv mecarbil, and which has shown positive results in the galactic HF. So at the present state of time, you can see we have multiple pathways which can target heart failure. And this certainly has improved the outcome of heart failure, particularly HFrEf. So let's see sacubitril valsartan. Now, these are the landmark trials of sacubitril valsartan, and all of us are very much familiar with them. And these are the trials which have paved the way for approval of sacubitril valsartan in heart failure. The paradigm HF trial, a 20% reduction in the primary endpoint of cardiovascular death and hospitalization for heart failure, paved the way in 2016 for approval of sacubitril valsartan in chronic HFrEf. The Pioneer HF trial 2019, a 29% reduction in the primary endpoint NT-proBNP concentration, paved the way for approval for ADHF after hemodynamic stabilization. The Paragon trial in HFrEf narrowly missed the primary endpoint, as you can see on the slide, but showed benefit in 2 subsets of patients, females and EF 45 to 57%, and has been approved for this subset of ejection fraction by US FDA. Now, this is the exciting reverse remodeling data from the PROVE-HF trial. You can see all parameters are favorably influenced. And this is the data which I was talking about. You can see 613 patients. At the beginning, all of them have ejection fraction less than 35%. All were eligible for ICD implantation. After a couple of 6 months, 32% patients have their ejection fraction above 35%, and they were ineligible for ICD. And after 1 year, look at 61% of patients, the ejection fraction increased to 35% with arni, and they became ineligible for cardiac ICD implantation. And look at the wonderful reverse remodeling effects of sacubitril valsartan. After 6 months, ejection fraction increased by 10%. After 12 months, it increased by 20%. So a new thinking is emerging for ICD implantation. Optimize use of arni before ICD implantation for primary prevention of STD. In fact, some people even talk it as a medical ICD. The LIFE trial failed, all of us know, with arni because as heart failure advances, chronic excessive activation of RAS blunts or overrides the effect of natriuretic peptides on the heart, vasculature, and kidney. The PARADISE trial also failed to show superiority of sacubitril valsartan, likely because there's no window of opportunity for titrating the dose in AMI, and hypotension is more common. SGLT2 inhibitors in heart failure. SGLT2 inhibitors are a panacea of heart failure. They're a boon for CKD. They're the molecule of the decade. And this is the current meta-analysis showing hospitalization for heart failure with SGLT2 inhibitors. And you can see across the board, SGLT2 inhibitors decrease hospitalization for heart failure, whether it is HFrEf, whether it is HFpEF, high-risk patient with ASCD, high-risk patient without ASCD, acute decompensated heart failure, or even CKD, and decreasing hospitalization, therefore, is a signature effect of SGLT2 inhibitors. SGLT2 inhibitors, even people have started saying SGLT2 inhibitors a day keeps heart failure away. And the benefits of SGLT2 inhibitors starts very early, and at the end of 28 days, you can see there's a significant benefit. And preventing hospitalization for heart failure with SGLT2 inhibitors is a great achievement in the treatment, because every rehospitalization takes the patient closer to death. And if you can prevent hospitalization, this is indeed a great achievement. And this is the landmark Emperor-Preserve trial, 10 milligram Emperor compared to placebo, a 21% reduction in the primary endpoint of cardiovascular death, hospitalization for heart failure, which is driven mainly by decreased hospitalization for heart failure, which is about 27%, no change in cardiovascular death, all-cause mortality. It did slow down the decline in GFR, but failed to improve the renal outcome in contrast to the Emperor reduced trial. All subsets benefited, less than 70, more than 70. Males also benefited, unlike the Paragon trial. Asians had better benefit, and where all subsets of ejection fraction, less than 50, 50 to 60, 60, and all other subsets, as you can see on the slide, they had a benefit. This is the DAPA-HF trial, 4,700 patient trial, was prematurely terminated and showed improved outcome in diabetic and non-diabetic HFrEf for the first time, 26% reduction in the primary endpoint, worsening heart failure, 30% reduction, cardiovascular death, 18%, and all-cause mortality, 17%. And very interesting data emerged. It also decreased ventricular arrhythmias by about 21%, driven mainly by reduction in the ventricular arrhythmias. All subsets benefit. This is the comparison of the DAPA-HF and Emperor. Both are same in terms of reduction in hospitalization for heart failure, but Emperor failed to show a statistically significant reduction in the all-cause mortality and the cardiovascular mortality. The two trials of sotagliflozin 2020 again showed fantastic data, and this is the pooled analysis, a 28% reduction in cardiovascular death, hospitalization for heart failure, urgent HF visit, HFrEf 22% reduction, HFpEF 37% reduction, but now we have the dedicated trial. And very interesting data emerged from the SCORE trial. Non-fatal MI, non-fatal stroke, cardiovascular death were reduced, which is not the usual story with SGLT2 inhibitor. A word about the sequencing of therapies in heart failure. The conventional therapy sequencing is no longer applicable. Milton and Packer suggested beta blockers and SGLT2 as preferential therapy, because SGLT2 inhibitor does not affect heart rate, blood pressure, eGFR, and potassium. And the ACC recommended arni as a preferential recommendation because of excellent reverse remodeling, but the guidelines do not recommend any preferential sequencing. But what is very important is that all these four drugs should be considered complementary to each other and never competitive, and all four should be on board within a spell of 1 to 4 weeks, depending on the heart rate, the blood pressure, the eGFR, and potassium levels. The mechanisms of SGLT2 blood are multiple, and I'm not going to discuss. As you can see on the slide, they also produce efferent effect on the efferent arterioles, and decrease in interstitial edema is one of the very important mechanisms for its benefit in HFpEF. They can be used across the continuum of heart failure, the cardiorenal continuum. And when we are treating heart failure, it is very important to remember that there's a very close cross connect between heart failure and CKD. Worsening heart failure worsens CKD, worsening CKD worsens heart failure, and therefore cardiologists, when we are treating heart failure, they should target the cardiorenal continuum and never heart failure alone or never kidney failure alone. Targeting kidney disease triggers benefit for heart failure, which has been the missing link which we have recognized. And look at the benefits in CKD. It's a boon for CKD, whether your patient has CAD or no CAD, HFrEf or CKD, there is improvement in the renal outcome. And SGLT2 inhibitors slow down the trajectory of CKD. They postpone dialysis by 15.1 years, which is indeed very exciting and revolutionary. All cardiologists must remember these 7 points when they are treating heart failure, and they should also focus on kidney failure besides heart failure. Then we have this soluble granulate pathways, vericiguat directly stimulates SGC and increases production of cyclic GMP, which provide protection to the vasculature and the myocyte. And this is the Victoria trial carried out in patients with recent warning chronic HFrEF ejection fraction less than 45%. You can see
1 minute left.
Statistically significant reduction in CV death or first hospitalization driven by hospitalization for heart failure. And NNT for this was only 24. It's once daily medicine, easy to titrate, generally safe and well tolerated without the need of monitoring of renal function. And then we have the omecamtiv mecarbil, which stimulates the cardiac myosin and has also shown an 8% reduction in the primary endpoint driven by decrease in heart failure when mortality was not affected. And iron therapy should never be forgotten. And this should be the fifth pillar for heart failure treatment if you want to improve the outcome. So in summary, drug revolution of 4 foundational drugs for HFrEF should be utilized for all patients of HFrEF as they provide incremental benefit on top of each other. All 4 drugs should be on board within 1 to 4 weeks. The sequence of initiation may vary depending on the blood pressure, the eGFR, the potassium, the heart rate. The 4 foundational drugs are poised to postpone device therapy and even cardiac transplantation. HFpEF no longer remains an orphan disease. Emperor Preserved trial is the first ever trial to show benefit of SGLT2 inhibitor HFpEF, and we're keenly awaiting the results of the DELIVER trial. Heart failure runs a malignant progression, and all therapies should be escalated to target dose unless side effects preclude their escalation, and one should not think of de-escalation because heart failure is never stable and potentially dangerous. Polypharmacy is the rule. Patient and family should be motivated to accept it. In heart failure, cardiorenal continuum should be targeted and never heart failure alone. Vericiguat is a new weapon approved for HFrEF to decrease recurrent hospitalization. Omecamtiv mecarbil is still undergoing evaluation. Iron therapy, very important. And prevention of heart failure has emerged as a very important agenda and is indeed possible. But the problem is guideline-based therapy for heart failure, highly underutilized, and adherence is suboptimal. And this is the basic unachieved goal. This is the Western data, the Indian data is worst. Thank you very much for your kind attention.
Sessions. So now the floor is open for discussion. Now Dr. Sahani, Dr. Wanda, Dr. Devakar Jain to conduct the
Thank you, Dr. Mahapatra. My question is to Dr. Manoria. Dr. Manoria, sir, we are seeing now a new phenotype of heart failure with improved ejection fraction or recovered ejection fraction. They're going back to around from 30 to 50 or 55% ejection fraction. The many times physicians and the patient ask this question: how long shall we continue this foundational 4 drug? As we know that we can stop diuretic except MRAs, but foundational drug should be continued with this patient. And we have a study from TED CHF showing that if you stop it, you go back with the low ejection fraction. So question is, how long shall we continue this? Number 1. And number 2, can we have in some stage in follow-up, can have a step down in the drug doses? Dr. Manoria, sir.
Yes, very nice question. Firstly, the concept of improved ejection fraction is a misconception. Heart failure usually never disappears, it continues to run a malignant progression. So your question whether we can step down treatment if the patient improves, the answer is no to vast majority of patients. Although there may be improvement in symptoms, but apoptosis continues unabated and suddenly you can land up hospitalization for heart failure, or in the early stages when symptoms are less, you can have a sudden cardiac death. So the aim of therapy in heart failure is escalation, escalation, and escalation to the target dose unless side effects preclude their use. However, there are some exceptions as you asked. Patients of peripartum cardiomyopathy or patients of myocarditis, they may recover to a great extent. And if you think of de-escalating therapy, ejection fraction should never be a criteria for de-escalation because you can have subclinical dysfunction, left ventricular systolic, even in the presence of a normal. So if at all you want to de-escalate, you must measure GLS also. If GLS and ejection fraction both are normal in a subset like a peripartum cardiomyopathy where the recovery chances are great, or in a myocarditis, you may think of, but that has also been done very good. But in vast majority of patients, it is escalation and no de-escalation, because the vast majority of cases of heart failure are due to a progressive disease and they do not regress.
So they, as you say, they are HFrEF in remission. I agree with you.
Yeah.
Question is that how long shall we continue?
It is an indefinite therapy for vast majority of
Yes.
patients.
Yeah.
Indefinite and indefinite.
Well, can I just chip in, JP here? Yeah, there is a study published in Lancet, which was Red HF or something. I don't remember
Red HF.
the name.
Red HF.
Red HF. That's what
Yeah.
he said.
So this distinctly shows that if you withdraw drugs, a lot of these people will come back with heart failure. And then when you second time reinstitute these drugs, especially the beta blockers and the afterload reducing drugs, you will not get the same amount of benefit. So what Dr. JP Sani and Dr. Manoria both are, I think, emphasizing is that this phenomenon of improved ejection fraction was never there prior to beta blockers and the RAS blockers. So now that we have seen this kind of an improvement in, see, beta blockers cause more improvement in ejection fraction than arnis. The maximum ejection fraction, in fact, is improved with beta blockers. So once you use a combination, obviously these ejection fractions, as Dr. JP is telling us all, will improve. Then one has to be very, one should not have the temptation of course, diuretics will be withdrawn in most of these people, but you will continue with beta blockers. I just wanted to ask this very august audience. I know some of you are strong protagonists of arnis over RAS blocker or other RAS blockers.
Hello.
What is your current clinical practice in terms of Dr. Chopra can tell us, and Dr. JP has such a vast heart failure patient population, Dr. Manoria and all these across the country, and I would say globe. What are your thoughts? Do you put your patients first on ACE inhibitor, ARB, and then switch over to arnis? And what is the current, because there are schools of thought in both directions. So let's kind of hear to all of you experts, how do you handle these situations?
Thank you very much, Dr. Wander. I think it's a very, very important question. I like to respond, and I think first of all, the previous question which was raised by JP Sani and was discussed by Dr. Pcmanoria, is no doubt that once we start arni or SGLT inhibitor, it has to be continued. We cannot reduce the dose. It has to be improved and sustained improvement. Sustenance is possible only if you continue the drug. It's just like tower or we do mitral clipping. We can't remove it when a patient improves. So we need to continue. That's the way. Second thing, I think Dr. Wander has asked regarding the role of arni as a first therapy or SGL2 as a first therapy. The answer is all the guidelines, whether this for HFpEF or for HFrEf. I think these four pillars are very, very important. We don't talk much of ACE inhibitors or ARB. ARB is there definitely in arni. I mean, there is no doubt about it. But there is a huge data coming up now on reversal of remodeling, which I mentioned there. A morphological remodeling, functional remodeling, and biochemical and biomarker remodeling, and even the cell reprogramming. This cell reprogramming will reverse. So I think things will change if you stop the drug. It has to be continued. And JP Sani was very firm in saying that how long should we continue? I answer is you should continue and follow this patient very meticulously. And I think it should be continued for a long term until and unless there is a condition like Dr. Manoria has mentioned on myocarditis, where we can reduce a little bit, but parameters should be there. A follow-up should be by echo and NT-proBNP. Echo is the real cornerstone. Thank you.
Yeah, I think it's sorry, go ahead.
The sequence of initiation varies on the subset of patients. There's no fixed sequencing. If you have a patient of heart failure with hypertension, arni will come number one. If you have a patient of heart failure, BP is 90, SGLT2 will come first, beta blocker will first. If you have an advanced CKD, suppose there's 30 EGFR, then again we'll have SGLT2 and beta blocker first. So all depends on the subset of patient. Whether arni will proceed or whether SGLT2 or beta blocker will depend, individualize these patients and will depend on the subset of the patients. You cannot have a dogmatic statement that arni has to be initiated first or SGLT2 or beta blocker. All depends on the subset of the patient. In one subset, I think, beta blocker may score, that may score.
The question Dr. Wander actually raised was very pertinent, that whether there are two types of thoughts right now, whether to start ACE inhibitors and ARBs and then switch over to arni or go direct to arni. I think, to answer to that is that, we don't have that head-to-head comparison study like this where we go direct to arni and we go from step 1 to step 2. But certainly with the data which we have, it is absolutely reasonable to go directly to arni also in those patients who are at least low ejection fraction, HFrEf patients, and those who have blood pressures which can actually tolerate this, and we can even start this in the hospital, period. And many times we do that. So I think it is at this time, we are extrapolating all that information, but definitely, and we have small data on in-hospital patients receiving arni straight away. So that arni therapy can be initiated as a first line therapy in these patients. And definitely it is one of the components. We are not saying, Dr. Manoria, that you are replacing everything. We are saying that, it has to be part of that therapy if the blood pressure and rest of the things renal functions are permitting. So I think, and the last thing, Dr. Sani, which was mentioning about how long, I mean, the answer, I don't think we have that clear answer as to for how long, even if the EF improves. If the EF is not improving, we have to continue. Yeah. But sometimes we see patients EF is 55% after 6 months or a 1 year course. So
I just like to mention, I just like to mention a comment here. Like Dr. Praveen Chandra has given a very important information, but there is a lot of data coming up. The EF should not be the only criteria. We have to think of LA strain, longitudinal strain, which is a very, very important variable, and the remodeling. When we talk of remodeling, it has to be all the 4 chambers. 4 chambers remodeling, data is emerging out. We don't have data at the moment, but a lot of data is emerging out. Even the anti-fibrotic component is by LA strain. So I think these are all new things which are coming up now, but ejection fraction per se is not only the parameter which we have to consider once we start arni or SGLT inhibitors.
Yeah, I think it's important that to explain the patient when they ask how long to continue, to me, I give them the example of like hypertension, diabetes, hyperlipidemia. The fact that you have controlled them doesn't mean that now you can stop the treatment. So I tell them it's no different than any of those entities. Control means the medications are doing the job. And in order to derive the benefit, you got to continue just like you will continue antihypertensive. Now, if the blood pressure is normal, that doesn't mean you stop it. So I think heart failure should be no different that if the medications have improved the ejection fraction, with a rare exception like Takotsubo or myocarditis, those may be different conditions, but vast majority of heart failure patients, even if they improve to a normal level, I think some dose of treatment, you may have to cut down on some of the doses, but they got to continue for indefinite period of time. The question is, will they eventually 10 years, 5 years later go again into heart failure or not? I think that issue remains unresolved. Some people do worry about it, that it is a relentless condition. Yes, you can improve their cardiac function symptom, but maybe 5 years, 10 years later, it will show further decline in function. That part remains unclear.
Just one question, Dr. Jain. I think a lot of patients which we see here who are in heart failure, and as Praveen Chandra and Dr. A.B. Baker just pointed out, when we give them a device therapy, like in the form of TAVI, or I know Praveen Chandra has done a lot of tricuspid valve, percutaneous valve replacement. So when we do device intervention and a patient is already on drug, does the drug requirement reduce? I have no answer. I'd like to have the comments of our chairpersons or any of our speakers.
I think the one thing which guidelines have come up, like you have given a device therapy when the ejection fraction was low, less than 35 or so, and suppose you were given an ICD or CI, and we found now ejection fraction is 60% and the battery life is over. So shall we replace the battery? That is the question which came up. I mean, the guidelines are in favor. I think if you are very certain that probably this patient ejection fraction is certain, we need not have to renew the battery in this patient. I'm not sure about, but I will ask my other colleague, Dr. Jain and Dr. Praveen, to answer this question.
This is a complicated question. I tell you my take on that. Those patients who get ICD as a primary prevention based upon ejection fraction criteria or any other criteria. Now, 5 years later, the patient has not used the device and they're due for replacement of the battery. It's not a part of the guideline, but I think probably we should consider, does the patient still qualify for, if this patient did not have a device, would you put the device now? If not, Why do we continue? Now, most in USA, the issues of liability, nobody wants to take their liability. It's much easier to replace it. And after all, money is involved in that too. So nobody has incentive to think. But in my opinion, one should consider, at least in a subset of patients where these ICDs are put in as a primary prevention based upon ejection fraction criteria, and ejection fraction has improved, and patient has never had device activation. Then at the time of replacement, you should consider, do we really need to do it? Then the question would come in, if you are not replacing the battery, do you extract it or just leave it there? To me, it looks like a common sense, just leave it there. If ever needed, you could replace the battery, but again, there are no set guidelines. This is a work in progress kind of thing that we need to raise the awareness and maybe come up with some agreement for that.
I just one question to Dr. Wander, Dr. Sani, and Dr. Chandra together. If you do LVAD, in LVAD, when a patient is already on a complete therapy of SGLT2 and arni, the requirement of these drugs reduce or it does not reduce. How do we prognosticate the patient who are on a heart failure therapy versus patient on LVAD or RVAD or BiVAD? We like to have opinion because people who are like Praveen Chandra or Dr. A.B. Mehta are doing these procedures and following this patient with the therapy. What's their experience?
Okay, so let me just answer this question in totality, that what happens after these procedures in low ejection fraction patients. In cardiomyopathy or ischemic cardiomyopathy, actually, if we are talking about, so those patients who are having ischemic cardiomyopathy, systematically, we assess whether these patients are having hibernating myocardium or they are totally infarcted myocardiums. So those patients who have hibernating myocardiums on cardiac PET CT scan or MRI scan, in these patients, definitely these patients improve after doing the intervention. And as you saw from the data from the Impella study and also from many studies where revascularization was done completely, full revascularization, the ejection fraction improves. And definitely these patients, the dose of these therapies can be reduced in these patients once the EF improves after revascularization. The second is those patients who have valve implantations like TAVR, or patients who are having mitral clip implantation, or those patients who have TMVR. In these patients, again, the dose of these drugs can be reduced quite dramatically, and diuretics are definitely off very initially. And once the EF improves in these patients who have undergone valve implantation procedures, I think it is reasonable to de-escalate therapy and if the ejection fraction is improved. The last question is about the CRT devices. Actually, for ICD, it is simple. If you can check, if there is no shock, there is no VT, and these patients have improved ejection fraction, there's no need to replace the ICD. But in CRT patients, the question is a little difficult. Because if the patient has improved after a CRT implantation, his doses are also reduced. And what to do with the failed batteries going. So in these patients, I think it is still reasonable to replace the batteries because we still don't know. We don't have the data that whether, if you don't replace the battery, whether the EF will go down again or not. So that's where the situation is right now.
Yeah, couldn't agree with you, Praveen, more than exactly what I was going to say, that ICD and CRT should be looked at in a different, totally manner. And ICDs, of course, all these issues once EF comes back to normal, no shocks, but CRT certainly one would, at least I would like to replace it because a lot of it would have been, CRT is an excellent form of therapy, we all know. We talk of newer therapies today, but CRT produces one of the most dramatic improvements in these patients. So one would certainly like to replace it. Just one short comment on sequential therapy. There was a trial which showed that beta blockers, once they are delayed to these people for a long time, I know we spoke about sequential, it can be kind of detrimental for some of these people. So once we have heart failure controlled, beta blockers should be instituted early. And this was a comparison between beta blocker first or ACE inhibitor first, and beta blockers scored over that. Now I was reading in JACC, there's a lot of people have collected together and given opinion on some of these studies. They show that these SGLT2 inhibitors can even be started pre-discharge, or so to say, rapidly after discharge. Although we don't have data in terms of trials, but certainly there are smaller studies. And so since there is so much promise with these agents, we have some sort of a consensus kind of an opinion which says they can be started pre-discharge. So early use of these drugs can be done.
Yes, EMPRISE studies published AHA 500 patients shown pre-discharge. EMPA has been given in HFpEF or HFrEf, diabetic and non-diabetic, and they have shown good results. So we can start safely. Single dose, no titration, no hemodynamic difficulty, whether improvement in renal function, prevention of hyperkalemia. So there's so many benefits. So I think safest drug to be given in heart failure patient as early as probably SGLT2 inhibitors.
Okay, we have a few questions from the audience for Dr. Manoria. I think maybe the 3 questions for Dr. Manoria. Do SGLT2 inhibitors have any antiarrhythmic effect? And the second question, I think you have let me just read all the questions so you can answer them together. Can we de-escalate drugs? I think that has been discussed in great detail. And also, another question for Dr. Manoria, you did not clarify SGLT2 benefits in all, whether it is all CKD or in some CKD patients.
SGLT2 inhibitors have definite antiarrhythmic action. I've already shown you the data of the DAPA-HF trial, the decreased ventricular arrhythmia. Regarding CKD benefit, it is more benefit for proteinuric CKD. But now for the interstitial disease of the kidney, we have a newer agent, finerenone, which targets inflammation and fibrosis. SGLT2 inhibitors and RAS blockers target intraglomerular hemodynamics. And in the Fidelio trial, 5% of patients were all on these 3 drugs. I do not have access to this data, which seems very interesting. So the approach for CKD benefit, if you want to target intraglomerular hemodynamics, RAS first and then SGLT2. And if you want to target interstitial disease, finerenone will have an edge, although there could be combination of both.
Any other?
Excellent.
I have a question to Dr. Manoria. Can I ask?
Yes.
Hello.
Short question, Dr. Parasa, please.
Yeah. What is the cut point of eGFR for using SGLT2 inhibitor? And what are the subset of the patient where the SGLT2 should not be used? Please.
The cutoff point for use of SGLT2 inhibitors varies. What is your aim of use of SGLT2 inhibitors? For glycemic control, the cutoff point is 45. For heart failure, it is 30. For CKD, previously it was 30, but EMPA CKD is running up to 20. So the cutoff point depends on the subset. If you are using below these, it becomes an off-label indications, which sometimes we have to use. The contraindications for use of SGLT2 inhibitors are type 1 diabetes. Usually we avoid very late stages of type